At 10 months old, our son would hold little board books flat up against his face, squishing his nose as if he was trying to see inside them. And I would think, how adorable. Look how much he wants to read. It turns out he couldn't see. He had dislocated lenses, the result of a yet unknown rare genetic disorder, causing the ligaments on the side of his eyes to pull his lenses outward and distort his vision. After several eye doctor appointments, we were referred to a surgeon. I'll never forget this day. It was a Thursday. This doctor insisted that our son's lenses needed to be surgically removed and went ahead and scheduled it for that Monday. As both a scientist and a mother, I asked a lot of questions. Are there other steps we can take? What are some of the things that could go wrong? Do we have time to seek a second opinion? The surgeon dismissed our concerns and took offense at my second opinion question. We left this appointment bewildered, with surgical prep documents in hand. That night, I took to the internet, I checked in with a geneticist friend, and the next day, a Friday, I contacted a preeminent eye doctor in a state far away. Who here knows what a Hail Mary football pass is? I sent this doctor a Hail Mary email. This is our son's situation. What would she suggest? Miraculously, on that Sunday, she replied, cancel the surgery, bad things will happen, go see this other doctor instead. Although we had not met this Hail Mary doctor, we instinctively trusted her. She heard our concerns and she responded quickly. This new doctor she recommended gave our son a thorough exam and prescribed highly specialized glasses. Our son, who had just turned 1 year old, fought us as we tried to put these glasses on, but once we finally succeeded, he looked around the room and said, ooh. He could finally see. This was the moment I realized that not all treatments recommended to patients are evidence-based. But it wasn't the last time I'd faced that reality. Patients should not and cannot throw Hail Marys for every clinical decision they need to make. We need to trust that healthcare is based on evidence. We need to trust that every medical conversation will be two-way, asking questions, receiving sound answers, and sharing in every decision-making process. But how can we make sure that evidence and trust is always part of healthcare? Braithwaite and colleagues warn us of the 60-30-10 challenge. Numerous studies have shown that 60% of current healthcare is based on evidence. 30% is low-value care, and it should be discontinued. And 10% of care, it's actually harmful, potentially like the surgery my son almost had. The good news, though, is that we have a solution to the 60-30-10 problem, and it's called implementation science. Implementation science is the study of methods and strategies used to integrate evidence into real-world clinical settings. This science makes sure that the healthcare that we receive in hospitals, in community-based clinics, in small private practices, no matter who we are, where we live, or how much money we make, is based on evidence. It turns out we need a science to make sure that healthcare is based on science. We created the Brown Research on Implementation and Dissemination to Guide Evidence Use program, the BRIDGE program, to do just that. BRIDGE is a great acronym for both our program and for bridging the gap between what we know works and the healthcare that any one of us receives. Getting the right care to the right person at the right time doesn't happen in a blink. Moving evidence into clinical practice moves at the speed of trust. It requires creating an innovation culture and helping both clinicians and patients learn how to become comfortable with new evidence. As an implementation scientist, I can ask questions to understand some of the potential barriers to this. Is it a lack of training or resources to provide that treatment? Is there organizational resistance? Are there cultural adaptations that we need to make? Once we know what some of those problems are, we can develop strategies for overcoming them. Let me give you an example. My colleague, Dr. Elisa Jalalian here at Brown and her team asked me to work with them to bring an evidence-based family healthy weight program to lower-income families here in Rhode Island. This program involves a coach working with a parent or a caregiver and their child between 6 and 12 years of age once a week over a 10-month period. Each child in this program has a high weight status. During the weekly sessions, the coach talks about healthy eating, tracking food choices, and increasing physical activity. Elisa and her team have shown through clinical trials that this program involving both parents and kids helps to stabilize kids' weight and improve their mental health outcomes. But how do we take this type of program out of a clinical trial and move it into everyday healthcare? Scaling this type of program is tough. Parents are really busy balancing multiple jobs, other children, maybe lacking transportation or babysitters. How do they and their child get to an in-person group meeting with a coach once a week for 10 months? I know that would be really hard for me to do. I am the queen of paying for health club memberships that I don't use, despite my best intention to exercise every week. So we asked families a simple question: what would get in the way of you participating in this program? And they told us, and we acted. We hired Spanish-speaking community health workers. These are people from the community where our families lived to serve as coaches so that we could hold sessions in the language that families preferred. We incorporated into our conversation of healthy eating more culturally relevant foods so that families could learn how to cook their own foods in a healthy way. Families told us that they needed more resources for finding fresh, affordable foods and low-cost or free physical activity programs for their kids. Our team put a website together of those resources. And then, just as we were about to launch the program, the COVID-19 pandemic hit. And we had no choice but to make this program virtual. Again, we asked families, what do you think about this? One mom said, online meetings would be so much easier. Our schedules are so hectic and we have other kids that we have to worry about in the family. Another mom said, the program's too far away and I don't drive. I know I can't commit to anything in person. A global health crisis forced our team to do what families needed us to do all along: remove barriers to participating in the program. So, our team delivered guidebooks and scales and tablets to each family's home for the virtual meetings. No more taking 2 buses to get to the health center where the program would take place. No more trying to find babysitters for the other kids in the family. In fact, the other kids could now hear the virtual lessons and participate in some of the programs, such as going on a scavenger hunt around their home to find as many healthy foods as possible. The program went beyond the parent and child dyad to ensure healthy eating for the entire family. And guess what? It worked. 111 families participated in the program. 10 months after starting, kids had meaningful improvement in their weight and their health-related quality of life. And kids who participated in more meetings did better. Importantly, children from homes that had greater food security were more likely to have improvement in their weight than kids who were from homes that were food insecure, a finding that has huge policy implications for the role that access to healthy foods has on weight. One mom told us that she says to her kids, I need you to eat more vegetables and less white bread. And now the kids understand why. But how can we expect kids to be of a healthy weight when access to healthy foods may be out of reach? We now need to demand that we have policies in place to promote evidence-based healthcare that families can access and benefit from. We need those with lived experiences to inform what we do in our day-to-day lives as health professionals so that we can move that 60% of evidence-based care to 100%, ensuring accessibility for all. We need to make sure that we share our lived experiences with policymakers to demand standards that remove low-value and dangerous care. And we must make the time to build trust with patients and families so that no family has to throw a Hail Mary like I did for my son. Our ability to bring an English and Spanish language virtual family healthy weight program to families here in Rhode Island didn't come from moving harder and pushing faster. It came from listening to families, incorporating their needs, and helping them to understand lived experiences and what they can do. If we want to make evidence-based healthcare the rule rather than the exception, we must align science, policy, and lived experiences. Systemic change in healthcare won't come overnight. It will move forward at the speed of trust with one relationship, one decision, and one story at a time. But if we don't take each step hand in hand with the people impacted most, all of our efforts will simply disappear in a blink. Thank you.